Hey, I'm Tanner Bernard.
Hey, I'm Megan Moody.
And I'm Catherine Morse, and we're all nursing students at Middle Georgia State College.
Our patient review deals with respiratory acidosis and the patient, Mr. Sam Williams. So without further ado, let's get started. Before we start talking about our patient, Mr. Sam Williams, I thought it best we do a little background information on respiratory acidosis. Okay, so the normal pH in the blood is 7.35 to 7.45. Anything above 7.45 makes the blood be more alkaline. Anything below 7.35 and the blood becomes acidic. An increase in CO2 will cause the blood pH to decrease and become more acidic. The normal CO2 levels in the blood are 35 to 45. Anything above 45 and you're going to see a definite pH shift to the acidic side. Respiratory acidosis can show signs in the body such as dizziness, confusion, hypoxia, which is too much oxygen in the body. Not enough oxygen in the body, excuse me. And seizures, ventricular fibrillation, and a decrease in blood pressure. This is caused by hypoventilation, which is the retention of CO2 because the lungs don't totally inflate, so they can't go get the CO2 to bring it out of the body. You'll notice this especially in diseases such as COPD, or if a patient's taking, say, morphine, it can cause respiratory depression, and they can see, decreased respiratory rate, and they won't be able to excrete the CO2, causing respiratory acidosis. Also, atelectasis, which is a collapsed lung, it also decreases the ability for the body to get rid of CO2, causing the pH to drop. You'll also see things such as, of course, the respiratory rate will try to reverse itself and get rid of more of the CO2, but a lot of times the metabolism has to correct respiratory acidosis. So you'll see the kidneys start to conserve HCO3 bicarb, which is a base, to increase the acidity and try to make it more alkaline. You also see a compensatory electrolyte shift, causing the body to go more hyperkalemic, which will put more potassium in the blood and less hydrogen ions, therefore increasing the pH, making it more basic because potassium is a base and hydrogen ions are more acidic.
Hey, I'm Catherine Morse, and I'm the nurse that's going to be taking care of Mr. Sam Williams today. Mr. Williams is a 60-year-old Caucasian male who came to the surgical unit after having a gastrectomy 2 days ago. He is complaining of pain, he is reluctant to deep breathing and coughing, he refuses to use the incentive spirometer, and Mr. Williams has a lot of respiratory secretions. He has a long history of smoking, bronchitis, and COPD. He receives non-opioid pain medications. Upon meeting Mr. Williams, I want to pay particular attention to his potential of acquiring an acid-base imbalance. After entering the room, I noticed that Mr. Williams is hypoventilating, which is characterized by slow, shallow breathing. After only a few minutes, Sam's condition worsens. He becomes less and less inclined to breathe deeply, despite me positioning him for maximal breathing, splinting his incision, and administering pain medications. Mr. Williams becomes increasingly restless due to his lack of oxygen, which is a common result of hypoxemia. Because of hypoventilation and subsequent impaired oxygen-carbon dioxide exchange, carbon dioxide level in the blood is accumulating and oxygen level in the blood is decreasing. Hypoxemia is a decreased oxygen tension in the blood, as measured by partial pressure of oxygen in arterial blood. Hypoxemia results in hypoxia, which is poor tissue oxygenation. Cerebral hypoxia causes restlessness. Restlessness is an early sign of cerebral hypoxia and may be accompanied by confusion and disorientation. When hypoxia is present, tissues including major organs are starved of oxygen. Sam has bilateral crackles and minimal airflow at the base of both lungs. His respiratory rate is 12 breaths per minute, and he is hesitant to take deep breaths. He is oriented but restless. A stat arterial blood gas and other blood work are drawn by the physician. With that being said, I'm going to turn it over to Megan for interventions.
Hey, my name is Megan, and I'm going to review all nursing interventions that will be done for Mr. Sam Wiliams. Since Sam is hypoventilating, I'm going to position him into semi-Fowler's position. For maximal breathing for semi-Fowler's position, the bed should be at 30 degrees. Sam is reluctant to cough since he is in pain, so I will show him how to splint his incision to help him cough easier. Before I get Sam to cough and deep breathe, I will administer his non-opioid pain meds so he will be more comfortable. Sam needs to do some deep breathing to increase ventilation and to decrease fluid accumulation in his lungs. Sam started showing signs of hypoxia. First, I called the physician and notified him about Sam having difficulty breathing and that he was being restless and agitated. Next, I auscultated Sam's lungs, which will detect any mucus obstruction that could interfere with gas exchange. After I listen to the lungs, I will check Sam's SpO2, which measures arterial oxygen saturation. This will determine if Sam needs O2 to be administered. Since his SpO2 was 90%, I will administer oxygen after I call the physician. If Sam isn't already, I will position him in semi-Fowler's position. This position will allow for optimal lung expansion and gas exchange. Sam has COPD, so the doctor prescribed him oxygen at 6 liters per minute nasal cannula. I question this dose because it is too high for a patient with COPD and could decrease the stimulus to make him breathe on his own. I'm not going to withhold the oxygen. I will just call the doctor and see about getting the order changed to a lower dose, maybe to 2 liters per minute, since 90% isn't too low. It is important for Sam to stay in semi-Fowler's position at 30 degrees so gravity can facilitate downward movement of the diaphragm. While intra-abdominal pressure on the diaphragm is minimized, this allows for optimal lung inflation. I will reposition him by alternating sides periodically. Side-to-side positioning helps move secretions out of the airways. During his stay in the hospital, Sam's pain medication is changed to an opioid analgesic in a low dose. With better pain control, we hope Sam will be more inclined to deep breathe and cough. The low dose will cause minimal respiratory depression. To loosen secretions, IV hydrations are cautiously increased. Postural drainage is ordered to help remove mucus secretions. And throughout the night, I'll encourage Sam to deep breathe and cough, and I'll document the color and consistency of any sputum. Now I would like to take the time to show how splinting, coughing, and deep breathing is done. Alright, proper technique for splinting is, and proper technique for breathing is in through your nose, out through your mouth. We hope you enjoyed our video.
And I hope we gave you a better understanding of our patient, Sam Wiliams, and his condition, respiratory acidosis. Mr. Wiliams becomes increasingly restless due to his lack of oxygen.
Hey, I'm Tanner Bernard.
Hey, I'm Megan Moody. And I'm Catherine Morse.
And,
Mr. Wiliams has a lot of respiratory secretions. I'm not liking the way this is going.